Good evening. Thank you, everyone, for being here today. Uh, Welcome you all to the Dr. Sarindar Mansingh Memorial Oration. Uh, to begin the proceedings, I'd like to welcome the Director, uh, Professor Srinivas, and the Dean, Professor Verma, for joining us for the oration. The oration is actually conducted by the All India Institute of Medical Sciences, New Delhi. It's not a department activity, it's an AIIMS activity. We also welcome all the other faculty members from the institute, students, and staff who've joined us for this oration today. Before we begin, I'd like to invite, as we begin, I'd like to invite the Dean, Professor Verma, to introduce the oration. Okay, all right, yeah. So, may I invite? Okay.
Thank you, Rajiv. Honorable Director Dr. Srinivas, I see the ex-heads of the departments, Dr. Gupta, Dr. Dogra is here, members of the faculty, delegates, ladies and gentlemen. It's my honor and privilege to welcome you all to this Dr. Sarindar Mansingh oration, which is in the memory of Dr. Sarindar Mansingh, who was the pioneer head of the Department of Urology at Indian Institute of Medical Sciences. Dr. Mansingh, born in undivided India, which is part of the Pakistan now, and he did his schooling from Doon School, Dehradun, and later he joined the medical college, King Edward Medical College at Lahore. But this was 1945, so soon after the division of the country, he had to be moved from that medical college to another one. So he was shifted to Stanley Medical College in Madras, where he graduated from as the best students and several gold medals, listed 4 and some silver medals also. Following which he did the FRCP, FRCS from England, and then he joined as faculty in 1958 at AIIMS Delhi. Of course, he had a very vibrant and brilliant career. He was chosen as Rockefeller Fellow and worked at John Hopkins Institute in the United States. And 73, when he returned back and initiated the department, he became the associate professor. In 66, he started the MCS program at AIIMS, and after that, a number of say the urologists have been trained who are now positioned in different places within the country and across the globe, heading the important positions, including different various chairs also. In 69, he became full professor and head the department, and he has been quite an impactful teacher, clinician, and a very progressive urologist and researcher. He had numerous publications to his credit at that time when the urology was evolving, and he devised several urological methods also for treatment of different urological problems. So by virtue of he is the founder of the urology, he was invited to the various universities as examiners and the experts on different occasions. He was also the editor of the on the editorial board of the British Journal of Urology, and he started Delhi Urology Society, which is meeting now. So the honor is very aptly today that we are having the Dr. Sarindar Mansingh Memorial Oration. We had the privilege and good luck that we were taught by him during our undergraduate days in early 80s, when we didn't understand much about urology, and we were wondering as to, is there really a necessity having urology as a different specialty? But now we see that yes, the expansion of the specialty, and once you grow and you understand the enormosity of the subject, you realize that yes, there was a need. But as undergraduates, you don't feel that yes, why for such a small organ you have a full department. He was a thorough gentleman, very kind-hearted, and always willing to help the students, the residents, and the patients all alike. And we invite people of feminists to deliver the oration on the subject of their choice. Previously, it has been done by Dr. S. V. Sharma, Dr. M.P. Gupta, who is amongst us, Dr. Mahendra Bhandari, whom I have been frequently meeting for different reasons. I don't see him here today, but yes, he has been visiting the institute on and number of occasions. Rajiv would remember. Yes. Dr. Hemal, Dr. Badlani, and last year it was Dr. James Andrew who delivered the oration. This year, this is going to be done by Dr. Steve Boorjian, who is the professor of urology and also the director of uro-oncology at Mayo Clinic. I'm sure that yes, you would enjoy the oration as much as you have enjoyed the other program of the of today. And I thank you all for having spare time this afternoon to be here, and welcome again to this program. Thank you.
Thank you, Professor Verma, Director Sir, respected superannuated HODs from our department, and my dear friends, colleagues, people from the Delhi Urology Society. It's a great pleasure to welcome you all for this Professor Sarindar Mansingh Memorial Oration. We have been organizing this every year, and you have just heard the list of illustrious speakers we have had for this very prestigious oration in the field of urology. In India, we all know that Professor Mansingh's name is a very, very respected name, and any person who's it's a privilege. A lot of speakers have considered this as a privilege to deliver this oration. And when I talked to Dr. Steve Boorjian, and he was also he was initially very keen to come here, but then later on he decided that he would have to do it online. And because of some confusion regarding the daylight saving hour, he will be joining us in another 5 minutes. So I'll take these 5 minutes to introduce the orator, Dr. Stephen Boorjian. He graduated from Harvard Medical School, so you can imagine he was amongst the best students in USA. And then he did his residency in urology at the New York Presbyterian Hospital Weill Cornell Medical College, which again is one of the most competitive centers to get into in the field of urology. And he followed it up with a fellowship in uro-oncology in Mayo Clinic. And he continued to stay there in Mayo Clinic, and slowly and steadily he rose to become the chair, the head of the department of urology there. And at present, he is the Carl Rosen Professor of Urology and the David and Ann Luther Chair of the Department of Urology at Mayo Clinic in Rochester. He is also the Program Director of the Mayo Clinic Urologic Oncology Fellowship Program. And he has co-authored over 500 manuscripts and book chapters, and he has his original research work in practically every field of uro-oncology. He has been the member of the NCCN guidelines panel for bladder cancer and penile cancer, and he has served as a member of a number of AUA committees. One of them is on non-muscle invasive bladder cancer guideline committee, and one has been a guideline committee for salvage therapy for prostate cancer guidelines. And today's talk is basically going to be concentrated on the salvage therapy after radical prostatectomy for prostate cancer, and he has been one of the members of the guideline committees of this American Urology Association guidelines panel. He has been an associate editor of European Urology across the Atlantic, so he has worked there also. And he is also currently a senior editor of the American Board of Urology Examination Committee. So, ladies and gentlemen, we'll just wait for Dr. Steve Boorjian to join. And as has already been announced, the title of his talk is going to be Evaluation and Management of Prostate Cancer Biochemical Recurrence, Balancing Disease Biology with Competing Risks. So we all know that some patients after radical prostatectomy will develop some biochemical recurrence, and where this PSA is coming from is sometimes a little confusing. It may be coming from the remaining benign prostatic gland, or there may be some micrometastasis. Then how to further work up, what are the various possibilities in the workup and management strategies. And then obviously one has to risk balance the whole situation. There are side effects of each and every therapy, and there are advantages of each and every therapy. So that is what he is going to talk about. So I think we'll still have to wait maybe for a minute or two before he comes. And there are two types of links for this oration. The first link has been provided to the members of the Delhi Urology Society, where it's a two-way link, where they may be where they may be asking questions. Although, as is standard practice in an oration, there are generally no questions or answers by the orator, because the oration is supposed to be a personal viewpoint or a personal experience. And but still, I think knowing him and knowing his personality, he is likely to be happy to answer questions. So we'll see at the end how much time do we have. So if we have some time, then maybe we can ask questions from him related to this topic, or even other topics also, because he has a vast experience of other things. And the second link is a YouTube link, which has been provided to members of the Urology Society of India, North Zone chapter, and a number of other forums where they can join and basically receive the signal, and they can listen to what is going on here. They will not be able to ask the questions. Welcome, Steve. I'm sorry regarding the confusion that has happened because of the daylight saving our time. And welcome. So we are all eagerly waiting for you. We have utilized this time. So we have utilized this time in introducing the oration and also introducing you. So you can straight away start with your oration. Thank you very much.
Yeah, I'm sorry, Professor Seth, would you like me to start with the talk or?
Yes,
with the?
yes, your talk is loaded, and because everybody was here, so we started with the initial proceedings. The initial proceedings included introduction of the oration and introduction of Professor Sarindar Mansingh, and
Wonderful.
talking about Professor Sarindar Mansingh, and then we have also introduced you, and your CV has been introduced, and your work, etc., has been introduced to all the speakers. And this is being live transmitted through two portals. One is a two-way interacting portal, which is the Google Meet portal, where you are there, and another one is the YouTube, which is a one-way transmission.
What's the best way for me to access the slides that I had sent you?
They are already here. Okay.
Okay. So the Mayo Clinic really started with this individual, William Worrell Mayo, who was a United States Army doctor stationed in Rochester, Minnesota, charged with providing physical examinations for soldiers to go into the United States Civil War. Can you see this now as I advance?
Yes. Yes.
Perfect. Okay. In 1883, a series of tornadoes destroyed the town of Rochester and completely eliminated all of the infrastructure, including medical care facilities. Shortly after that, Mother Alfred Rose, who was stationed at a local convent, is said to have had a vision from God that she should build a hospital. And she went to Dr. Mayo and asked if she built the hospital and funded it with the church, would he and his two sons, who had now been in medical training, stay in the town and become the first staff of the hospital. And that's really how Mayo Clinic began. These are what are known as the Mayo brothers, Will Mayo and Charlie Mayo. They were the first doctors and the surgeons of the Mayo, and that's really who the Mayo Clinic today is named after. This is St. Mary's Hospital when it opened in 1889. Again, built and funded by the nuns. They were the first nurses of the hospital, and Will and Charlie have since built the enterprise. This is what our facility looks like today. This is St. Mary's Hospital currently. It's a little over 1,100 beds. This is our downtown campus and our office building. We would welcome any and all of you to visit us in Rochester. Now, in terms of my financial disclosures, they're all in non-muscle invasive bladder cancer. They're actually hidden behind this because I've taken off animation, but none of them are relevant for this topic. And really what I'm going to focus on is walking through the AUA Astro SUO guidelines that were released last year. Now, in order to understand AUA guidelines, I think it's helpful to know a little bit about how AUA guidelines are constructed. AUA guidelines are put together by a multidisciplinary panel that includes radiation oncology, medical oncology, and a patient advocate. We use a methodology that's called the PICO methodology. It develops research questions a priori and then conducts a systematic literature review. For those who have seen our guidelines, you have seen that each guideline statement is assigned what's known as a strength of evidence based on the certainty that the supporting literature lies close to the predicted estimate. So, the way I'd like to organize this talk in speaking about biochemical recurrence is to first cover what do we understand about defining, risk stratifying, and imaging evaluation for biochemical recurrence. We will then move into treatment with salvage radiation therapy for biochemical recurrence, and we'll finish with a few words about emerging data on salvage systemic therapy for non-metastatic rising PSA. Now, even before as surgeons we think about biochemical recurrence, a very common clinical question that we face is what should we do with the patient in whom we've done surgery, we've identified adverse pathology, extraprostatic extension, seminal vesicle invasion, positive margins, high-grade disease. A long-standing question has been, should we treat those patients with immediate or adjuvant radiation therapy, or should we wait and treat those patients if they have biochemical recurrence with salvage radiation? Well, we now have 3 prospective randomized trials that have helped address and inform this question, and data from those trials then put together into a meta-analysis. I'll show you here the largest of those trials. It's known as the Radicals trial. It involved 1,400 patients here, and I'm just going to use animation for a second, just so that you can see. I don't know if you can see this, but I thought it would be helpful to show you the criteria of the trial, randomized either extraprostatic disease, high-grade disease, positive margins to immediate adjuvant radiation or salvage radiation for a PSA greater than or equal to 0.1. Now, again, here's what the trial found. The trial found that there was no significant difference in the 5-year biochemical recurrence-free survival between patients treated with adjuvant radiation or patients treated with salvage radiation. You can see the p-value here. And in fact, those patients who got adjuvant radiation significantly worse urinary continence and increased urethral stricture disease. As I mentioned, the data from that trial, as well as 2 other trials, were put together into this meta-analysis published in Lancet. It's called Artistic. Over 2,100 men. The take-home point from this trial is that there is no evidence that event-free survival is better if we do immediate radiation therapy after surgery, even for adverse pathology, versus if we wait and if a patient experiences biochemical recurrence, as we'll talk about, use early salvage radiation. So, in fact, our clinically localized EUA prostate cancer guidelines tell us we should not routinely recommend adjuvant radiation after radical prostatectomy. Now, that really brings us to the concept of biochemical recurrence, and I think when we start talking about biochemical recurrence, it's important to understand what do our guidelines strictly define as biochemical recurrence. And here you can see the AUA defines biochemical recurrence as a PSA after surgery greater than or equal to 0.2 with a second confirmatory value greater than or equal to 0.2. So the first take-home point from my talk is that based on AUA guidelines, it really does take 2 PSAs in order to define biochemical recurrence. Now, again, I'm going to switch just briefly to animation. While it's important to understand our guidelines, I also think it's important to understand when we go into clinic today that not all patients with a detectable PSA after surgery are at the same risk to then experience progression of disease to metastasis. And with that concept in mind, these investigators from Cleveland Clinic did a study where they looked at 14 different definitions of biochemical recurrence, and they correlated them with a patient's disease risk as estimated by a nomogram predicted 5-year progression risk. And they generated a variety of curves. But really what they found here that's important, I think, to take away from this study is that if a patient had a nomogram predicted 5-year progression-free survival less than 50%, indicating clinically very high-risk disease, then the best definition of biochemical recurrence is actually just 1 PSA greater than or equal to 0.05. On the other hand, if a patient has a nomogram predicted 5-year progression-free survival more than 90%, indicating clinically low-risk disease, then the best definition of biochemical recurrence is a PSA greater than or equal to 0.4 and rising. So the take-home point from this study, and the second take-home point I want to leave you with from the talk, is that we may use a lower threshold of PSA to define, and as we'll talk about, even to treat biochemical recurrence in patients who have clinically higher risk disease. Now, how can we do early detection of biochemical recurrence? What we may utilize is what's known as ultrasensitive PSA. Ultrasensitive PSAs are assays that can detect PSA levels less than 0.1. What's the rationale to use ultrasensitive PSA? There are data from NYU and others that have shown that a higher ultrasensitive PSA value may correlate with a subsequent increased risk of biochemical recurrence. Now, I think we have to be very careful, and I'll be interested to hear from you all if you use ultrasensitive PSAs in India. I will tell you at Mayo, we do not. There are several concerns that we have about ultrasensitive PSAs. There are no prospective trials to evaluate ultrasensitive PSAs as a metric of guiding further therapy. There are no established cut points of ultrasensitive PSAs that have been associated with definitive increased risk of subsequent biochemical recurrence. And when we're talking about PSA levels that low, we have to be thoughtful that we may be catching an indolent PSA recurrence or even the presence of benign prostate tissue. So the guidelines do include a second statement, and that is if you use an ultrasensitive PSA and you find a detectable ultrasensitive PSA, you should confirm a rising trend before proceeding with therapy. So a very important point here is don't treat on the basis of a single ultrasensitive PSA alone. It's important to confirm a rising trend if you are using that type of assay. Now, I will spend one slide on biochemical recurrence after radiation therapy. What should you know about it? First, how we define it. It's known as the Phoenix criteria, which is the nadir PSA a patient achieves after radiation plus 2. Second, what do the guidelines tell us about how you should evaluate a patient with biochemical recurrence after radiation? The guidelines state that for a patient with biochemical recurrence in whom you are thinking about salvage therapy, you should document a prostate biopsy to establish the presence of a local recurrence. And what does it mean? It means that in 2025, if a patient has a rising PSA after radiation and you get a PSMA PET scan, for example, and the PET scan is active in the prostate, that by itself should not lead to further treatment. You should do a biopsy first. What happens if you document positive disease in recurrence on biopsy? Then shared decision-making, patient and doctor, we should be offering these patients salvage radical prostatectomy, salvage cryotherapy, HIFU, or re-irradiation. Now, back to biochemical recurrence after surgery. What's important to know about it? What's important to know about biochemical recurrence after radical prostatectomy is that the natural history is heterogeneous and maybe quite prolonged. What do I mean by heterogeneous? What I mean is that biochemical recurrence really always comes before systemic progression or death from prostate cancer, but biochemical recurrence by no means always precedes to systemic progression or death from prostate cancer. There are many more men who have a detectable PSA after surgery than will ever develop bone metastatic disease or have a serious risk of death from prostate cancer. And that again emphasizes the importance of considering a patient's age and competing risks. In fact, one study from Sloan Kettering demonstrated that patients with biochemical recurrence were as likely to die in the next 15 years from one of their competing risks of mortality as they were to die from prostate cancer. Now, what do I mean by the natural history of prostate cancer can be quite prolonged? We have several different observational series that have documented the long-term natural history. This is a study that was published now over 25 years ago out of Johns Hopkins in JAMA, but some of the data here remain very relevant for our practice today. They followed a little over 300 men with biochemical recurrence for just over 5 years, and what they found during that time was a third of patients with biochemical recurrence developed metastatic disease. The median time from biochemical recurrence to metastatic disease was 8 years. The median time from metastatic disease to death from prostate cancer was 5 years, which gives us a window from biochemical recurrence to death from prostate cancer of 13 years. Quite prolonged. And again, we have to remember that this was 25 years ago before we had any of the life-prolonging therapies that we now have in advanced prostate cancer that's going to extend this duration even longer. Long-term natural history, we've got to remember the competing risks of mortality when we're thinking about any type of treatment. We've had an interest at Mayo Clinic as well in looking at the long-term natural history of biochemical recurrence. We evaluated in our series over 2,400 men with biochemical recurrence with a follow-up just over 11 years. And likewise, we found that the cancer-specific survival 15 years after biochemical recurrence approached 85%. The vast majority of these patients are going to live for a long time without significant disease consequences. In our series, about a quarter of these patients received salvage treatment at the time of biochemical recurrence. Now, again, thinking about how we can risk stratify patients with biochemical recurrence, this is one risk model. I'll show you several different ways that we can estimate a patient's risk of death from prostate cancer after experiencing biochemical recurrence. This is a nomogram that was put together from a little over 2,200 patients with biochemical recurrence who were followed for just about 4 years. These are the variables that are included in the nomogram here. This is a published risk model that you can use to estimate and counsel patients. They included age at diagnosis, and that's sort of an indication of competing risks. They included PSA parameters, PSA doubling time, time from surgery to biochemical recurrence, and then they included pathology from surgery, Gleason score, surgical margin status, tumor stage, and lymph node status. And again, you can see you can calculate 5, 10, and 15-year risk of death from prostate cancer. Now, the EAU has published a much simpler risk model. Instead of a nomogram, they use risk groups, and the risk groups are defined by only 2 parameters, Gleason score at surgery and PSA doubling time. And you can see here how they define low-risk biochemical recurrence and high-risk biochemical recurrence. They've actually already validated these risk groups in over 1,000 men with biochemical recurrence with long-term follow-up. And you can see here how the curves nicely separate risk of cancer-specific survival between high and low-risk biochemical recurrence. So I show these to you as 2 risk models that you may use in practice for counseling patients. Now, the AUA in our guidelines does not specifically endorse one risk model. What we say is that you should use prognostic factors, and we've included a table in the guidelines of just these factors we've talked about: Gleason score, tumor stage, lymph node status, PSA doubling time, in counseling patients about their risk of clinical progression. Now, it's very important when we're thinking about competing risks that we don't forget the risks that the patient harbors as well. And specifically, we talked about the competing risks of mortality. This is a nice study that was done by Steve Freeland and colleagues here, looking at competing risks of death among men with biochemical recurrence. They analyzed 1,200 patients with biochemical recurrence who were followed for over 5 years. The key variables that they identified in competing risks was patient age and Charlson comorbidity status. So they generated curves that look like this, and I think are very informative. What they found is that if a younger patient who had no comorbidities experienced biochemical recurrence, their risk of death from prostate cancer, which is here in blue, is very close to their risk of death from other causes, which is here in black. These curves are pretty close. On the other hand, if a patient who's older and has a significant number of comorbidities experiences biochemical recurrence, their risk of death from prostate cancer is very, very small compared to their risk of death from other causes. You can see here that the separation of these curves is much greater. So we have to consider age and competing risks when we're asking ourselves, is this patient with biochemical recurrence more likely to die from prostate cancer or from other causes? Now, when we have biochemical recurrence, the next important question to ask is how should we stage these patients with imaging? And when we think about the terms conventional imaging, that's bone scan, CT, MRI. When we think about the terms molecular or next generation imaging, that's PSMA PET. The data to support using PSMA PET to stage patients with biochemical recurrence comes from several different prospective trials. This is one trial of over 600 men with biochemical recurrence. Had PSMA PET, the results of the PSMA PET were compared to a reference composite standard. They demonstrated that the positive predictive value of the PSMA PET scan in biochemical recurrence was 0.92. They also demonstrated very nicely that the likelihood of a PSMA PET detecting disease directly correlated with the value of the PSA when you're getting the scan. So, for example, if a patient has biochemical recurrence and you wait until their PSA is 5 and you get the scan, the likelihood of a positive scan is over 95%. And we're going to come back to that number at the end of the talk. But on the other hand, and another take-home point that I want to leave you with here is even if the PSA is very low, less than 0.5, between 35 and 40% of patients had a positive scan. So even in early biochemical recurrence, we do recommend obtaining a PSMA PET scan because in a substantial proportion of patients, you may detect recurrent disease that could change management. Now, a second prospective trial here is known as the Condor trial, phase 3 trial, 208 patients with biochemical recurrence who had negative or equivocal conventional imaging. They then had a PSMA PET scan, and that scan was compared to a reference standard. What they found was that the correct localization rate was about 85%. And once again, what they showed in this Condor study was that the ability of the PSMA PET to detect recurrent disease in men with biochemical recurrence directly correlated with the value of the PSA. Once again, if the PSA is more than 5, 95 to 100% of patients will have a positive scan. Once again, even if the PSA is less than 0.5, 35 to 40% of patients will have a positive scan. This is an ongoing phase 3 randomized trial that's trying to look at whether or not getting a PSMA PET actually improves oncologic outcomes. They are randomizing men with biochemical recurrence after surgery either to get radiation therapy or to get a PSMA PET scan and then maybe get radiation therapy depending on the results of the scan. The primary outcome of this study is going to be 5-year biochemical recurrence-free survival, and because this is ongoing, that has not yet been reported. But what they published last year was the impact of the scan on change in management. And what you can see here is that nearly half of the patients who had a PSMA PET scan and were randomized to that arm had a change in their management. The majority of these were directly because of scan results. So the scan might have found disease outside the pelvis, and they might have canceled the radiation therapy. Now, what do our guidelines tell us about getting PSMA scans? Our guidelines tell us that in patients with biochemical recurrence, we may obtain a PSMA PET scan. On the other hand, our guidelines tell us that in men with biochemical recurrence, for whom we are considering salvage radiation therapy, we should perform a PSMA PET scan. Why should we do it if we're going to do salvage local therapy? Because we want to exclude from local treatment those patients who have extrapelvic or distant metastatic disease. Now, on the flip side, it's critically important that we are careful about recognizing even the limitations of PSMA PET. And what I mean by that is that if you're considering salvage radiation, the guidelines recommend getting a PSMA PET. But if the PSMA PET is negative, very importantly, the guidelines state we should still go ahead and do the radiation therapy. We should not withhold radiation if the PET scan is negative. Why? Because the detection rate of these scans is still not high enough at that low level of PSA to potentially detect microscopic disease in the prostatic fossa that may be present and may be effectively treated with radiation. So get the scan if you're going to do radiation, but don't withhold the radiation if the scan is negative. Is there any role to also get conventional imaging in addition to PSMA PET? And the guidelines tell us that yes, we may obtain a pelvic MRI as well. Why? Because there are data that show a potential enhancement of detection of prostate bed recurrence with MRI as well as PSMA PET that may then guide salvage therapies. Now, when we move from salvage, understanding the natural history, to treatment, a very important first question before we talk about treatment is to ask whether or not salvage treatment of biochemical recurrence can impact what we've just looked at its natural history. Now, here we don't have prospective trials to guide us of men who were randomized to either salvage radiation or no salvage radiation. But what we do have are a series of observational cohort studies that have very consistently told a similar story. These are data from Johns Hopkins in a follow-up series to the one that I showed you earlier. Now they had 635 men with biochemical recurrence, of whom 238 got salvage radiation. And with a median follow-up of 9 years, what they showed, as you can see from the curves here, in retrospective data that we have to acknowledge may be subject to selection bias, is that among men with biochemical recurrence, those who got salvage radiation, significantly better cancer-specific, significantly better overall survival. Very similar type study, now in over 1,800 patients, of whom a third received salvage radiation. They had long-term follow-up. They used propensity score statistical modeling to help adjust for the confounders and bias that may be present in such a retrospective study design. And what they found here is that among men with biochemical recurrence, again, those who got salvage radiation, significantly better metastasis-free, significantly better overall survival, and here these results were maintained on multivariable analysis. And that really brings us to guideline statement number 1, is that we should inform patients who we are counseling regarding salvage radiation that the benefit of salvage radiation therapy is most effective when given at lower levels of PSA. And that's really the concept of what we call early salvage radiation therapy. Now, the data to support early salvage radiation comes from several different series. These are from our Mayo Clinic radiation oncology group, a little over 1,100 men treated with salvage radiation and followed for 9 years. And what they found was that the key prognostic factor was the pre-salvage radiotherapy PSA. So what they showed here in these curves was that among men getting salvage radiation, those who got salvage radiation with a PSA less than or equal to 0.5 in the blue curves had a significantly lower risk of secondary biochemical recurrence, significantly lower risk of developing distant metastatic disease, and significantly lower risk of death from prostate cancer. A similar study now in 2,500 patients treated with salvage radiation and followed for 5 years showed if you got salvage radiation with a PSA less than 0.2, your subsequent 5-year biochemical recurrence-free survival was over 70%. If your PSA was between 0.2 and 0.5 when you got your salvage radiation, your biochemical recurrence-free survival was still over 60%. But what you can see is that as the pre-salvage radiotherapy PSA gets higher, the cancer control estimated by 5-year biochemical recurrence-free survival is worse. So what do our guidelines tell us? Our guidelines tell us that we should do salvage radiation therapy when the PSA is less than 0.5, and for the highest risk patients, we may even offer it at a PSA less than 0.2, very early salvage radiation. Now, a common clinical question that comes up when we're talking about salvage radiation therapy to the prostatic fossa after surgery is whether or not we should add radiation to the pelvic lymph nodes as well. We now have a prospective randomized 3-arm trial to help inform practice. This is called the SPORT trial. It took men getting radiation after radical prostatectomy for biochemical recurrence, and it randomized them into 3 arms: prostate fossa radiation alone, prostate fossa radiation with short-term ADT, or prostate fossa radiation, short-term ADT, and pelvic lymph node radiation. The primary endpoint was freedom from progression, and the follow-up was just over 8 years. And what they found, as you can see, is that the cohort who received pelvic lymph node radiation, significantly better progression-free survival, significantly lower risk of death from prostate cancer, significantly lower risk of developing distant metastatic disease, but no difference in overall survival. On the flip side, those who got pelvic lymph node radiation did have higher, greater than or equal to grade 2 toxicities in the acute setting, and in a late setting, they had greater than or equal to grade 2 blood or bone marrow events. So, how do our guidelines interpret these data? Some oncologic outcome measures improved, no difference in overall survival, and some toxicity. What the guidelines tell us is that we may expand radiation to include the pelvic lymph nodes, But if we're going to do that, we should discuss the increased side effect profile with patients. A second question that comes up when we are thinking about salvage radiation therapy is whether or not we should add androgen deprivation therapy to the salvage radiation. And here we have several prospective clinical trials to help inform us. This is a French trial that took patients getting salvage radiation and randomized them to 6 months of ADT with the salvage radiation or not. Over 700 patients. Primary outcome that they looked at was progression-free survival. And what you can see here is that patients who got 6 months of ADT together with salvage radiation had significantly better progression-free survival with a hazard ratio of 0.5. They published a follow-up long-term analysis which confirmed the results from their primary publication. Adding 6 months of ADT significantly improved the outcomes of men getting salvage radiation. Now, this is a second study, and again, I apologize for toggling on and off this, but I wanted to show you the outline of the trial published in the New England Journal of Medicine, led by Bill Shipley and the group from MGH. They took men getting salvage radiation and they randomized them to 2 years of high-dose oral bicalutamide or not, again, over 700 patients, now 13 years of follow-up and the primary endpoint of overall survival. What they showed was adding 2 years of high-dose oral bicalutamide significantly improved overall survival, significantly decreased the risk of death from prostate cancer. So what do our guidelines tell us? Our guidelines tell us that we should offer ADT in addition to salvage radiation for patients with any of the high-risk features that I showed you earlier, including lymph node-positive disease. We should discuss with patients the side effects of ADT and the impact of ADT on their existing medical comorbidities, and that for patients who are getting salvage radiation and don't have any high-risk features, we may offer radiation alone. Now, when we're going to do salvage radiation, how long should we be administering therapy? The guidelines tell us a minimum of 4 to 6 months. In the highest risk patients, we may even extend the ADT for up to 2 years. Now, of course, right after our guidelines are published, new data comes out, which people challenge us, people discuss, and I think it's very important to put into the context. So the month after the AUA guidelines were published last year, 2 studies came out from the Radicals group, 2 separate randomized trials that both evaluated whether or not we should be adding ADT to patients getting salvage radiation. This is the first of the 2 trials, nearly 1,500 patients getting radiation after surgery, randomized in this study to 6 months of ADT or no ADT. The primary endpoint was metastasis-free survival, and the follow-up was 9 years. And you can see here, the majority of these patients were getting salvage versus adjuvant radiation. The majority got prostatic phosphoradiation. The majority received GnRH analogs. What they showed here, very interesting, was that adding 6 months of ADT to salvage radiation did not significantly improve 10-year metastasis-free survival. You can see the p-value here, and they looked at it across a variety of different subgroups, and consistently, 6 months of ADT did not improve metastasis-free survival in this study compared to no ADT. Now, same issue of Lancet, they have a second randomized trial from Radicals, same investigators here, again, a little over 1,500 patients. In this trial, they randomized patients getting salvage radiation to 6 months or 2 years of ADT. The primary endpoint, similarly, metastasis-free survival, and again, the median follow-up was just about 9 years. Both patients had prostatic phosphoradiation. You can see this was a cohort of early salvage radiation, very low PSAs when they were getting their radiation, and most got a GnRH analog. But interestingly, in this study, what they found was that adding 2 years of ADT to salvage radiation did significantly improve metastasis-free survival compared to 6 months. So the first study, no benefit to 6 months versus 0 ADT. In this study, benefit of 2 years versus 6 months. And once again, they looked at a variety of different subgroups here of patients, regardless of their pre-salvage radiotherapy PSA. Adding 2 years of ADT significantly improved metastasis-free survival compared to 6 months. On the other hand, very important to note that those patients who got long-term ADT, not surprisingly, had a higher, greater than or equal to grade 3 toxicities. Now, how do we reconcile the 2 findings from these trials? Okay, we have two trials, both from the radicals group, which on the surface have very different findings. And what I think is really important to understand these two trials is to look at the entry criteria of the patients. So this is the trial of no ADT versus 6 months. This is the trial of 6 months versus 2 years. And what I've highlighted that to show you here is that the patients in this trial here of 2 years versus 6 months had significantly higher risk disease. The risk of having Gleason 8 to 10 tumors was about 30% versus 10%. The risk of seminal vesicle invasion, 30% versus 15%. Node positive disease, 8 versus 3%. And Kappa statistical modeling, high risk, 50 versus 33%. So what the take-home point here is that the patients in this trial were enrolled at higher risk. The trial was better powered to detect a difference in events. And I believe that's why this study showed a benefit of 2 years versus 6 months of ADT with salvage radiation. And I would say that these two trials support the guideline. Add ADT to salvage radiation in the higher risk patients, don't need ADT with salvage radiation in the lower risk patients. Now I'll finish with, in just the last few minutes of this talk, discussing salvage systemic therapy. For example, ADT for patients with a non-metastatic rise in PSA biochemical recurrence. These are observational series, retrospective data that have looked at whether or not adding ADT and treating men with biochemical recurrence using hormones alone was of benefit. This study, a little over 2,000 patients with biochemical recurrence after either surgery or radiation, no benefit in all-cause or prostate cancer mortality by treating patients with immediate androgen deprivation therapy. This study was nearly 6,000 patients, and what they found was that in the highest risk patients, PSA doubling time less than 9 months, treating them with ADT did decrease all-cause and prostate cancer mortality, again, in retrospective data. There's only one prospective clinical trial in this study. It was done out of Australia and New Zealand. It's called the TOAD trial. They took almost 300 patients with biochemical recurrence primarily after radiation. They randomized them to immediate androgen deprivation therapy or the androgen deprivation therapy at least 2 years later. Follow-up was 5 years. And what they did show was that the 5-year overall survival was significantly better in patients who got immediate versus delayed ADT. Although the trial was closed early to accrual and there are some statistical considerations, I do think it's important to recognize prospective clinical trial data. So what do our guidelines tell us? Our AUA guidelines do not recommend routinely treating patients with non-metastatic biochemical recurrence using androgen deprivation therapy. They recommend either observation or clinical trial enrollment. If ADT is considered, it should be done as intermittent rather than continuous. But again, right after guidelines are published, we have new studies that come out which challenge us. And of course, at the end of 2023, we had the EMBARK prospective clinical trial published in the New England Journal of Medicine. This study took men with biochemical recurrence after either surgery, radiation, or surgery plus radiation who had a PSA doubling time less than 9 months, so a high-risk cohort, and they randomized them into 3 arms: enzalutamide plus Lupron, Lupron alone, or enzalutamide alone. The primary endpoint in the trial was metastasis-free survival. The follow-up was just over 5 years. And what they found here, and again, I'm sorry, I'm going to have to go to this, was that in either enzalutamide alone or enzalutamide plus Lupron arms, treatment significantly improved metastasis-free survival compared to Lupron alone. They looked at a variety of different secondary endpoints, and very consistently, treatment with enzalutamide improved all of the outcome metrics that they analyzed. They also looked at the impact on quality of life, and they found treatment with enzalutamide did not result in a substantial deterioration of patients' quality of life. So at the end of 2023, the US FDA approved enzalutamide for the treatment of patients with non-metastatic biochemical recurrence with or without androgen deprivation therapy. So I think it's important to know, at least in the US, enzalutamide is approved. I would challenge this study. I think it's very important before we all go out and start treating patients with enzalutamide that we critically evaluate that trial. The median PSA at the entry into that study was 5, and patients in the EMBARK trial were staged with conventional imaging, not PSMA PET. So remember the data I showed you earlier. What is the likelihood of having a positive PSMA PET in biochemical recurrence if your PSA is at least 5, it's over 95%. So the question remains, was this a true non-metastatic population? We don't know the impact of treating so early with enzalutamide on subsequent therapies, and of course, it's a costly medication. Coming back here, we must remember it's critically important that in patients with biochemical recurrence, we recognize we are treating largely asymptomatic men, many who will live for years without any disease-related consequences. So what do I want to leave you with here in conclusion? For patients with adverse pathology at surgery, PSA surveillance with salvage radiation for biochemical recurrence is the favored strategy over immediate adjuvant radiation. Biochemical recurrence, know the AUA definition, but recognize it in the context of disease risk, and we talked about some of those high-risk features. Remember that the natural history of biochemical recurrence is heterogeneous and may be quite prolonged, so very important to consider competing risks of mortality. Evaluate the patient with biochemical recurrence using a PSMA PET scan, especially if you're going to consider salvage radiation, but don't withhold the salvage radiation if the scan is negative. When we talk about salvage radiation, earlier is better, for sure less than 0.5, maybe even less than 0.2. We may offer radiation to the pelvic lymph nodes. We should offer ADT in higher risk patients. In terms of salvage systemic therapy, don't routinely utilize ADT alone. Yes, in the US FDA, enzalutamide is now approved, but remember its toxicity, remember its cost, and remember that long-term natural history of biochemical recurrence. So with that, I want to stop. Thank you very much for this invitation. I apologize for the timing and the computer glitches here, but again, it's been my privilege and honor to be able to share this talk with you.
Thanks a lot, Steve. That was excellent. And I'm sure everybody here in this hall and all the people who are online would agree that Steve is an excellent teacher. He is he's a compulsive teacher, and the way the whole lecture has gone on, he has been teaching like like taking a class, and he is extremely popular in one of the very important AUA activities every year, and that is the landscape of prostate cancer. That activity is a whole day activity carried out by the Society of Uro-Oncology, and he's one of the prominent teachers, where they use a flipped classroom modality of teaching, where they divide the class into small groups where they discuss, and the discussant comes and discusses with each and every person. Steve, I'll take this opportunity to introduce you to our director. If you had been personally here, that would have been the first thing. Professor Srinivas, he is a pediatric surgeon by training. Right now, he is the director and the chief of our institution, and he'll be doing the honors, giving you all the awards. And the awards would be received on your behalf by people here, and then they'll be handed over to you once. Hopefully, we'll meet in during the AUA.
Who is taking to him?
I plan to go for the AUA, and he is so hopefully I'll take him. So can I request Geeta and Sunil to come and receive this bouquet on behalf of. Steve, we have Geeta and Sunil. Geeta is Dr. Sarindar Mansingh's daughter, and Sunil is Dr. Sarindar Mansingh's son-in-law. They are here. They come every year for this, and though they are not doctors, they don't understand. But it's.
Well, thank you, Bo. Thank you for that, for attending and for this.
So, can I request? We have Professor Gupta here, who was the chairman of our department. He superannuated in 2010. Now he's still very active and very busy in practice, and so I'll request him to take this the award on your behalf, and then later on I can carry it.
Other round, I think he can give it to you. You are carrying it anyhow.
Okay. No. This is
Why don't you come here? It'll be
as
easier
the
for him to
director-
see you, sir.
As a director, it is your privilege to.
That is very kind. Thank you so much.
We
Yeah.
both can give it to him. No, it's okay. Yeah. No, but he can say he's giving you.
Okay.
So, So this is the certificate for you, and this is the plaque. So,
Aye, sir, aye.
Oh,
Yes.
wow.
One lobe,
So-
another lobe.
so Professor Dogra is the other super invited head of the department from our department, and
That's amazing.
so
Well, congratulations.
Thank you. I will have to leave room in the suitcase.
Thank you.
That's very special. That's really, really nice. What is on the, that's a clock?
That's a plate. That's a plate that you can put up on the wall in your office.
A plate. I'm sorry. Yes, thank you.
Yes.
Beautiful.
That is a picture of the All India Institute of Medical Science.
Thank you.
Thank you, everyone. We'll come to a close for this oration. Typically, we have no question answers on an oration, but if you would like to stick around and ask questions, I guess we can ask Dr. Boorjian to stick around for a little while, but we'll call a close to the formal part of the oration. Normally, the oration is closed by the Associate Dean. He's not here today, so I'll do the honors on his behalf. We'd like to thank Dr. Boorjian for accepting our invitation and delivering the oration today. It is a prestigious oration, and we are proud to have had you deliver it for us this time. It's the 8th oration this time. We'd also like to thank the director for having been here throughout the oration, the dean who was here to initiate the oration, members of the faculty and staff of the institute, the department, and of course our guests, members of the Delhi Urology Society who sat through the oration today, and many others who are online watching us either on Google Meet as well as those who are watching us online on the YouTube channel. So thank you everyone for having been here and for having been a part of this presentation. I believe there will be tea available for everyone at the boardroom.
For him also.
In the pantry. Okay, so it's been brought up here for you. So the tea is being served in the pantry outside. If you have any questions for Dr. Boorjian, anybody in the hall would like to ask something, I believe he'd be okay answering them. Again, this is not traditional. We don't have question answers on orations, but yeah, it's not easy to get him online and having him here. So if he's here, sure, he'll be happy to take questions if there are any.
Absolutely. Happy to.
Right, I think Dr. Gupta would like to ask you something.
He will hear.
Yeah, you can use this mic, sir. He can hear you.
Boorjian, thank you very much for your lecture. The question I want to ask you, because of the anxiousness of the patient, when they see they have got a PSA of 0.3 or 0.4, and they don't have a very high risk factors, sometimes we like to give only one sort of androgen LHRH agonist, and they are very happy, and we just keep them under follow-up. And they may require second injection after 1 or 2 years. So the role of intermittent androgen blockade in this category of patients.
Yeah, so, and in fact, our AUA guidelines say if you're going to do androgen deprivation therapy in the setting you're talking about, you should do it exactly that. It should be intermittent. I will say that, and I understand that difficulty of navigating the patient's anxiety and the patient level, their priorities and their risk tolerance. The issue is that we don't have great evidence that ADT is of benefit in terms of preventing prostate cancer mortality or all-cause mortality. I think certainly in a patient who had a more rapid PSA doubling time, less than 9 months or so, then I would understand, and be able to counsel them. I really think this is where it takes quite a bit of time in counseling with that patient to explain, and hopefully with some of the statistical models I showed you, maybe even to quantify for them, here's your risk in the next 15 years of death from prostate cancer. Perhaps with that, for some patients, quantitative understanding, they will accept surveillance rather than even that intermittent hormone therapy. So I agree, intermittent can be used in that setting. It's supported by our guidelines. I try as much as possible to show the quantitative risk. And for that patient who really has a very slow rise, like you described, 0.3, then maybe 0.4 a year later, the likelihood that patient is going to experience progression is quite low, and I think can be observed.
Thank you for that. Yeah, Rishi, you want to have a question?
hello. I am Dr. P.P. Singh. There are few patients in our practice who are high-grade disease, have got a PSA doubling time less than 9, presumably immediately after radical prostatectomy. When we offer them radiation therapy, they are quite hesitant. Now, what do you recommend for this group of patients who have had surgery, have a high-risk disease, and do not accept salvage radiation?
They don't accept surveillance radiation. Well, and they have a rising PSA.
They have positive margins, high-risk disease, and they are just on following radical prostatectomy immediately. Like say around 6 months, the PSA doubling time seems to be more than less than a year, but they don't accept salvage. Do you recommend androgen therapy for this group of patients?
Yeah, great question. That's really tough. If they're not going to accept salvage radiation, I would say that there's two options. Well, now in the U.S., there's three options. One option would be, as you mentioned, androgen deprivation therapy. And yes, if they have high risk, rapid doubling time, I think it's one option to talk about with them. As I mentioned at the very end of the talk, in the U.S., we now have enzalutamide that you could use either alone or with the androgen deprivation. But I'll tell you, I think a third option, if a patient is really not going to accept salvage radiation and they have a rising PSA, they have negative imaging, another option, which is not supported by guidelines, but you could do, is you could say, okay, we're going to watch, we're going to get serial PSMA PET scans, and then when a scan detects something, treat with specific directed therapy at what you find. So, for example, if they won't accept just blanket salvage radiation therapy to the prostatic fossa, perhaps you follow them, and if a pelvic lymph node becomes positive on a scan, then you could just do stereotactic radiotherapy to that one lymph node. So I think you have to understand a little bit about why the patient is refusing, but one option you could offer is just surveillance with metastasis-directed therapy if and when the scan becomes positive.
Understand. Thank you.
Thank you. We'll just take a last question, Rishi. Good morning, Dr. Boorjian.
Morning, Dr. Boorjian. Can you hear me? Yeah.
It's quite a low. I can't hear that well.
Yeah. So earlier we used to do radical prostatectomy for mostly low risk disease or intermediate risk disease. The higher and very high risk disease constituted just about maybe say 30 to 40%. But now their numbers are more than 60% at most centers. And the radiotherapy series for BCR actually comes from the older era, whereas the recent trial, EMBARK trial, now comes for a relatively recent era. So now in the current scenario, how do you triage your patients actually to decide between radiotherapy versus EMBARK? Do you use any specific markers like maybe seminal vesicle involvement is a more important marker to for the patient to be having metastatic disease versus a localized disease where radiotherapy would be beneficial?
Yeah, that's a really, really good point that I did not bring out in the talk, which is all of the data, as you said, is really been from an era when we operate on lower risk disease. So it is likely that some of the features of that natural history will be shorter and more aggressive in higher risk patients. I'll tell you, I don't use one or another specific marker to your question about, how do I estimate disease risk? Lymph node invasion is the biggest one, obviously. Gleason score, yes, seminal vesicle invasion. Much of it, though, I think you can also glean from PSA kinetics. So time from surgery to initial biochemical recurrence, obviously shorter interval, higher risk disease, and then also PSA doubling time. So what do the kinetics look like? And I think there is a difference of 0.15 to 0.3, for example, over a 6-month interval than the other patient we were talking about, 0.3 to 0.4 over a year. So I would use a combination of pathology at surgery to define that risk, and then PSA kinetics. Is that the question you're asking?
Yeah, yes.
Right. Thank you very much, everyone. Thank you, Dr. Boorjian, for taking those questions. Thank you for joining us 6 a.m. in the morning. I guess you need to get ready to go to the war now. Thank you very much for joining us, and thank you everyone for joining us. Please join us for a cup of tea in the pantry outside. Thank you.
Very nice to see you all. Thank you. Look forward to seeing you soon.
Right. Thank you.